1919 was an auspicious year in history. The First World War ended, ushering a drastic change in the world order. The Philippine Islands had been a U.S. territory for 2 decades and was promised independence under the Jones Law of 1916. Progressive reformers saw the country and its people as a major target for modernization, and education was its main weapon. 7 forward-looking Filipinas came together in 1919 to create a school where young women could gain the knowledge and skills that would make them modern women. Paz Marquez Benitez was the first president of the Philippine Women's College. Jose Abad Santos was its first chairman of the Board of Trustees. Francisca Tirona Benitez was the second president, and with her husband Dean Conrado, guided the school from a house on A. Flores Street to its iconic Taft Avenue campus. In 1932, the college became a university, making PWU the first university for women in Asia founded by Asians. It provided a space where innovations in education flourished, and young people were encouraged to be the best that they could be. For over 100 years, the Philippine Women's University has been known as a leader in quality education. In 1934, PWU moved into its main campus on Taft Avenue, and since the 1970s has been co-educational. Located in the heart of Metro Manila, it is easily accessible by public transport and surrounded by affordable housing. Today's PWU offers undergraduate and graduate courses in several fields of study. Its business and management programs are responsive to the needs of industry, using evolving technology for global competence. PWU graduates excel in arts and sciences, education, social work, and diplomacy. Its fine arts and music programs have produced outstanding graduates through a holistic education that treasures heritage as well as excellence. PWU has pioneered in fields such as food science, nutrition and dietetics, medical technology, pharmacy, and nursing. PWU continues to play an essential role in producing graduates who possess the skills that make them competitive in the country and anywhere in the world.
A united community.
We may not be blood related,
but we Patriots are one big family.
Being part of the PWU community strengthens us.
Through the years, we support each other through good times and bad times.
We Patriots always have each other's back.
It's a big honor to be part of a community that is open to the ideas of each other.
Drives us to excel and be the best version of ourselves.
That's the standard of excellence that we Patriots strive for.
I'm thankful that this community lets us be who we want to be.
We thrive because we accept each other for who we are.
And like a family, we treat each other equally.
Actually, PWU gave us a home and helped us to be a patriot in society.
We may have different individual drums and instruments,
but we march with the same beat together as one united community.
Do you want to march with our community of patriots?
I am a patriot.
I am a patriot.
I am a patriot.
I am a patriot.
Hello everyone and welcome to today's webinar. Thank you for taking time out and being here today. I am Christian Bert A. Martinez and I will be your moderator for today's webinar entitled Healthcare Innovations in Time of Pandemic. I'm sure that all participants are excited and glad to be here today. We, graduate students, have prepared a very interesting topic to help us gain more knowledge in current trends and issues in nursing with our well-esteemed guest speakers. But before we start, let's discuss what our participant will be expecting for today's webinar. Our objective, our participants will be able to complete a nursing webinar under the subject current issues and trends in nursing and apply the learning in their field of specialization. Second, our participants will be able to learn and expand their knowledge of the concept of telemedicine. Last, participants will be able to identify the palliative care approach and what are the role and responsibilities of palliative care nurses in the Philippines. Before we proceed, I just want to express my gratitude to our God for guiding us and making this webinar come from fruition. May we call Ms. Jessica Rojas to lead the invocation, which will be followed by singing of our Philippine National Anthem.
Let us all bow our heads and put ourselves in the holiness of God, the Father, the Son, and the Holy Spirit. Dear God, thank you for all the blessings you have bestowed upon us. We are truly grateful for them. Thank you for allowing us today to meet and share our knowledge and time with one another in this webinar. May you extend your divine wisdom to our speakers so that they would be able to effectively impart their God-given knowledge to all of us. May they be blessed as they continue to bring their expertise to people who need them. Bless the participants as well so that they would be able to glean the vital information from this activity. May you bestow your blessings after this webinar so that we may go out and spread what we learned in the spirit of your love and generosity. We pray that you bless all the committees in charge that they may be able to fulfill their task responsibly, that the objectives they have set may all be achieved. Your infinite blessing would mean the success of this webinar. May we be a living witness of your genuine love through the enactment of knowledge acquired through this activity. May we realize that this activity should glorify your name. Amen.
silanganan, alam ng puso, sa dibdib mo'y buhay. Lupang hinirang, duyat ka ng magiting, sa manlulupig, di ka pasisiid, sa dagat at bundok, sa simoy at sa langit mong bukaw, may dilagang tulad, awit sa paglayang minamahal, ang kisap ng watawat mo'y tagumpay na nagdidigdig, ang bituin at araw niya kailan pa may di magdidinig, lupa ng araw ng at ipagsintabay langit sa piling mo, aming ligaya dapat may mga api ang mamatay ng dahil sa'yo.
Thank you very much, Ms. Cheska, for the graciously offering this webinar to God. We, the webinar organizer, would like to welcome you again for attending today's webinar. May I also greet our fellow colleagues all over the world who are attending today. Welcome to all of you. We are also live at Philippine Women's University official Facebook and YouTube page. Hello everyone who is watching from these platforms. Please do not forget to hit the like, subscribe to our official pages. We would also like to acknowledge the presence of our honorable program chairs and deans in this meeting room and invited guests. Thank you very much for joining us today. 2 years ago, the 7.5 billion people on the earth would not have predicted the enormous impact of COVID-19. A lack of preparedness was a major contributor to the struggle experienced by healthcare organizations. PPE are for healthcare workers, essential care for patients. One of the effective strategies that has been used is telemedicine, and it will broadly discussed by our guest speaker, Ms. Marinette De Vera. Before we start, a little reminder to our participants, may we request everybody to be on mute during the session so we can listen well to the speaker and minimize any noise or distractions in the background. You can send in your questions through the Q&A section so we could see it right away and it will be addressed during the Q&A portion. We would like to remind everyone that attending this webinar, you will be able to obtain a certificate of participation after filling up the evaluation form. Expect the certificates in your email. I hope you are getting excited now for the lecture today. Before we go there, let us call on Ms. Jenny Ann Bautista to introduce our first speaker.
Good day, everyone. Our first speaker was born and raised in Santiago City, Isabela. She earned her degree of Bachelor of Science in Nursing from University of La Salette in 2007, and her Master of Science in Nursing, major in Maternal and Child Nursing, from the same university in the year 2010. She started her career in nursing as a volunteer nurse in Echagui General Hospital in 2008, and later on became a staff nurse 1 in Al-Hada Armed Forces Hospital with specialization on ophthalmology, ENT, plastic surgery, and general surgery. Ms. De Vera is currently the head nurse of outpatient department in Al-Hada Armed Forces Hospital. She plays a major role in patient flow project called INSEAB and has been recognized for her shared project on nursing optimization in OPD and patient experience projects. She is part of the housing committee to ensure a safe and environmental friendly housing for our nurses in the institution. Without further ado, I am proud to introduce to you Ms. Marinette Rivera, MSN, RN, to present telemedicine clinics.
A pleasant day to everyone. I am Ms. Marinette F. Rivera, and I will be speaking about telemedicine clinics, an outpatient clinics connecting patient into the world of technologies, a virtual care. Outlines of my presentation. My objective at the end of this presentation, we are all expected to learn the concept of telemedicine and its history, to expand knowledge on the advantage and disadvantage of telemedicine, enhance our concept on telemedicine application. The American Medical Association has estimated that around 60% to 90% of clinicians have begun using some form of telehealth service since the beginning of the pandemic. However, one of the main changes that remain is optimizing this field for operation beyond a global pandemic. This is where the use of innovative technologies in telemedicine comes in. Technology is a growing part of healthcare in diagnosing, treatment, consultations, and even follow-up. Telemedicine is a growing part of our technology nowadays. What are the driving groups? To reduce the cost of care, to increase accessibility to healthcare, and then there is an increasing consumer demand as well. It demonstrated success at treatment in the face of reduced time to acquire care, enhanced patient convenience, and addresses the staff shortage of nursing. What is telemedicine? Telemedicine enables video or phone appointments between a patient and their healthcare practitioner. It benefits both health and convenience. It uses an interactive audio and video telecommunication system that permits real-time communication between the distant site and the patient at home. Telemedicine, telehealth, and telemonitoring are all subsets of telemedicine. Health organizations are providing virtual appointments and are expanding their telehealth options, particularly in the light of the COVID-19 pandemic. Improved technology has made telemedicine easier, even for those who consider themselves computer savvy. Patients can use telemedicine through the hospital online platform or mobile application and can access a virtual visit. Then let's move on with the history of telemedicine. Way back before, the telemedicine is already started. In the year 1844, by the name of Samuel Morse, a professor at New York University, developed a form of the telegraph in the 1830s that used an electric current to move an electromagnet attached to a marker that left a written code on a piece of paper. What was the earliest non-real-time telemedicine initiatives? Telemedicine circa in 1924, a visionary cover of radio news depicting an imagined radio doctor who could see and be seen by his patient. But the first experimental television transmission did not occur until 1927. The first people to use video communication for medical purposes were clinicians at the University of Nebraska. In 1959, the university established a two-way television setup to transmit information to medical students across campus, and 5 years later, linked with the state hospital to perform video consultations. A doctor's diagnosis by radio on the cover of February 1925 issue of Science and Invention magazine, The Teledactyl. Let's move on to the journey, and I will walk you through to the journey of the teledactyl. In the wake of COVID-19, we have all adjusted our ways of working. Some health and social care professional services were in a position to turn to telehealth using telephone and video to maintain service levels, keep up with the demand for services, and keep themselves and service users safe. So the question is the concept of telehealth new? Of course, no. In fact, as early as 1879, a Lancet article talked about using the telephone to reduce unnecessary visits to the doctor's clinic. In the 1920s, a magazine, Science and Invention, put forward the idea So let's move on to the journey to the teledactyl. In the wake of COVID-19, we have all adjusted our ways of working. Some health and social care professional services were in a position to turn to telehealth using telephone and video to maintain service levels, keep up with the demand for services, and keep themselves and service users safe. So, the question is the concept of telehealth new? No. In fact, as early as 1879, a Lancet article talked about using telephone to reduce unnecessary visits to doctor's clinic. In the 1920s, a magazine, Science and Invention, put forward the idea that doctors would use television and microphone and look after their patients via a teledactyl, a device with appendages that would respond to remote manipulation by the physician, allowing the doctor to feel his patient as it were at a distance. One of the most famous uses of hospital-based telemedicine took place in the late 1950s, where a closed-circuit television link was established between the Nebraska Psychiatric Institute and Norfolk State Hospital to facilitate psychiatric consults. What are the concepts of telemedicine? It consists of telehealth service provider, GHMP service provider, and a patient at home. We had also the telehealth service customer. What is meant by telehealth services? The Health Resources Services Administration defines telehealth as the use of electronic information and telecommunications technologies to support long-distance clinical healthcare, patient and professional health-related education, public health, and health administration. So who are the telehealth service customer? This type of at-home telehealth is sometimes called direct-to-patient, direct-to-consumer, or on-demand care. The telehealth service customer in Saudi Arabia, we have the emergency numbers that we can contact if we need a public ambulance through calling 997 or either a general emergency by calling 112. These are all sorts of telemedicine. According to research, before the pandemic, 11% of consumers reported using telehealth in 2019. Now, during the pandemic, 50 to 170 times increase the number of telehealth visits than the pre-COVID-19. 64% of physicians view telehealth more favorably than before COVID-19 challenge. 76% of consumers are now interested in using telehealth. In the future, after the pandemic, they viewed that 50% of executives believe 1/4 of the outpatient, preventative, and long-term care would become virtual by year 2040. And 94% of executives believe next-generation data sharing and interoperability solutions enable clinical care teams to share most of their patients' health data by 2030. So what are the benefits of telemedicine? First is patient outreach. It extends reach and expand healthcare service to patients. Effectiveness. Present more effective use of clinicians' outpatient slots. Conveniently monitor and manage long-term patient care. Assist physicians to serve more patients. It minimizes patient access and workforce limitation issues. Prevent delay of diagnosis for certain deadly condition diseases. And prevent the spread of airborne infections such as COVID-19. The advantages of telemedicine. It has easy access to all the specialists in the hospital. It lowers the cost. It has medical access for people in undeserved areas. It reduces the exposure to pathogens and control of infectious illness. To help prevent the spread of COVID-19, flu, and other infectious diseases, doctors can use telehealth appointments to pre-screen patients for possible infectious diseases. It also saves sick people from having to come into the clinic and less exposure to other people's germs and helps everyone, especially those who are chronically ill, pregnant, elderly, or immunocompromised. Next is reduced medical overhead costs. Support for people with chronic conditions, primary care, and chronic condition management. With the regular visits with primary care practitioners, such as those specializing in family medicine, internal medicine, and all the other aspects of specialties, are essential to our family's health. Telemedicines make it easy to connect with a doctor or other healthcare practitioner. Some systems are set up so that new patient can get an appointment with the next available practitioner, which can save their time. It either also reduces the anxiety of our patient and increase patient engagement. Not only do virtual visits reassure patients that their providers are available and involved in their care, it makes it much easier for them to reach out with questions, report early warning signs, and make follow-up appointments to make sure that they are on track. And not but that the least is the patient confidentiality. Like any other services that we are offering in the market, there are some drawbacks of telemedicine. First, of course, we does not allow laboratory exam, specifically for patients with chronic conditions who take medications and needs dosage adjustment. And also, through telemedicine, we will not be able to have physical examination with the patient. But in the light of the pandemic, we are able to manage these types of challenges. Limited bandwidth, internet connection, the laws and custom rules, especially in Saudi Arabia, the technical trainings and equipment. The telemedicine in Saudi Arabia was first launched by King Faisal Specialist Hospital and Research Center. In 2010, the MOH conducted a study in the adoption of telemedicine. In 2011, the Ministry of Health launched the first national project for telemedicine, referred to as the Saudi Telemedicine Network or STN, covering all healthcare facilities. The MOH cooperated with Canada Health Infoway and Ontario Telemedicine Network to provide guidance in developing a telemedicine roadmap for KSA. The STN roadmap, which was issued in 2013. Now let's talk about the telemedicine in Armed Forces Hospital Taif of Saudi Arabia. Our hospital is having a 560-bed capacity hospital that provides primary, secondary, and tertiary medical services to the Saudi Arabian military personnel and their dependents. This is one of the majestic view of our place in Taif. Our outpatient department has 12 clinics with 38 clinic subspecialties. We are running 410 clinic sessions in a week. The clinic specialties that provides telemedicine through virtual clinics are nephrology, dermatology, pulmonology, infectious disease, endocrinology, and cardiology. This is a sample of our virtual clinic patient portal, wherein patient can enter their medical ID, if it's expatriates or foreigner, their ICAMA, and for Saudi citizen, their national ID, and enter their password. This is the main portal of the our website, wherein you can see the digital ID of our patient. This is the patient portal with the telemedicine options here, the virtual clinics, and then the patient portal for virtual clinic. It will show them the schedule of our virtual clinics. So how telemedicine works in Armed Forces Hospital here in Taif. For the patient side, patient will need to log in hospital website with the username and their password. The patient will have the option to choose the services, including virtual clinic. So you see, it is not only the virtual clinic that we are offering. We had a lot, as we can see in the previous slide, we have a lot of services that we can offer, like to refill their medication, to request a medical report, and so on. So on physician side, the physicians can pick on an option whether he or she wants to see the patient as follow-up through physical visit or virtual visits, depending on the patient's discretion. So let me show you a sample video and a small explanation of our physicians on how the telemedicine works on our hospital.
This is the virtual clinic. You'll open this virtual icon. And then after that, I just type here the code of the doctor, KP03. Then password 123. Then enter. Then type the date from here. Today is 27, 2020. 02, 23, 20. Then click the
How long do you need this thing to be?
Good morning. We'll speak today about virtual clinic in our nephrology clinic. Today we are covering kidney transplantation patient. Actually, virtual clinic solved the big problems that we faced during COVID pandemic. It gives us a chance to follow up and see our patient. As you know, kidney transplant patients are immunocompromised. Risk of infection is high. We are so keen about them. So to keep our service and the continuity of medical service to them, we create this virtual clinic, which solves this problem. It gives us chance to follow up our patient and to provide them with the medical service while they are at home without exposure to infection, or they didn't have to attend and take appointment, which will be maybe risk of infection will be higher. Even we can provide this virtual clinic for patients who cannot attend, like big bound, multiple comorbidities. So it gives us a chance to help this sector of patients. To do a virtual clinic, patient, we send the link for him, and he has to be online with us. So I can contact him through our computer. First of all, I will check his file, his lab. I ask him how is he, if he has any concern, any complaint. If he wants to ask any questions, something active he's facing, any problem he has. After that, I will check his labs, comparing it with the previous one, and check his progress, if he's improving or not, if any active issue or new event in his labs. After that, I will revise his monthly medication. If I will have any modification in his medication, I will change any doses. As you know, kidney transplant patients are on immunosuppressant medication that we have to do trough level and follow up for them. So mostly we are dealing either to increase or decrease the doses of this immunosuppressant medication. So I will revise with the patient his home medication one by one, and what is the dose he's receiving, and also time, and everything regarding his medication. Also, I will explain to him if I will add new medication or discontinue any medication. I will inform him, and I will tell him why, or the reason for the continuity or discontinuity of any new medication. After that, I will tell him about my long-term plan also. At the end, I will give him like provisional assessment. How is his current situation, and what is my next step also? Like, for example, the next visit, I might add to do any specific investigations, add specific images to continue to optimize the medical service for this patient. Finally, I feel that it's a great success to face this pandemic and to continue providing medical service for our patients. And inshallah, I hope it will be continue even after this pandemic finish, for this group of patients who cannot attend our hospital. And thank you.
So as my conclusion, in Saudi Arabia, there are approximately 400,000 outpatient appointments every week, almost 80,000 per day, comprising a mix of new referrals and follow-up patients. The use of telemedicine can play an important role to reduce the risk of patient harm and mitigate some of the growing risks associated with the steadily increasing workload backlog. While it may be challenging at first, it is undeniable that telemedicine is the future of medicine and patient care. Thus, adaptation of the practice is crucial in healthcare institutions. Before I end this presentation, allow me to leave you an inspirational message that always inspires me on becoming a nurse. Too often, we underestimate the power of a touch, a smile, a kind word, a listening ear, an honest accomplishment, or the smallest act of caring, all of which have the potential to turn a life around. Be proud on becoming a nurse, as we are all God's given gift to everyone. Thank you. That concludes my presentation. Thank you, everyone.
Thank you so much, Ms. Marinette De Vera, for that informative lecture. We are truly grateful for the knowledge you share in this webinar. We will see you later for the question and answer portion. I hope you are getting excited now for the next lecture today. Before we get started, I would like to express my sincere appreciation to all of you who are generously help us make this event come together to become a success. It gives me a great pleasure to introduce to you one of our guest speakers today, Ms. Milagros Nuez. She completed her Bachelor of Science in Nursing at University of Eastern Philippines on 1997 and finished her master's degree in nursing, major in family health nursing at the same university on 2008. With doctoral units, she is also a TESDA national trainer for caregivers since 2016. She worked as a staff nurse for 3 years, a clinic nurse for 5 years, and clinical instructor or associate professor for 12 years to the College of Nursing while working as a palliative care nurse since 2013. With her compassion and dedication to share her knowledge for future nurses, presently is now a training specialist of Active Care Home Health Solution Inc. and a co-founder of Palliative and End-of-Life Care Association of the Philippines, or PIOLCAP. Please, we all welcome Ms. Milagros Nuez.
Thank you very much, and good afternoon, everyone. So it is really good to be with you today, and thank you for this opportunity. So when I was invited to give this talk, the title was proposed to me, Roles of the Nurses in Palliative Home Care in Philippines. So I know that some of you are very much intrigued how palliative care at home transform the role of the nurse from the hospital setting to home care. It changed. So a constant change and a turning point for nurses, to continue to grow and develop and learn how our career path has changed. So I am delighted to be able to reflect questions with you. And I have some slides to share and some insights and ideas on how nurses work at home. So it's ended a game changer. So in our healthcare system, as we finally integrate a palliative care at all levels of care, from the hospital to the homes of our patient. And its central aim is to help people live well until death across the lifespan in all practice settings. So all nurses have a fundamental role in a palliative approach to care, and palliative care must be accessible to all. So on these slides, as you can see, two nurses, or the palliative care nurse provides individualized care to patients who are likely to remain in the comfort of their home. So some of the other benefits of choosing in-home palliative care includes a greater peace of mind and comfort for the patient and family, and support the palliative approach to death. As presented on the 2015 Quality of Death Index, which was released by the Economist Intelligence Unit, published by the Lin Foundations of Singapore, ranking the end-of-life care across the 80 countries. The Philippines is the third worst place to die. So 6.1% of populations is 65 and over, so many with a lingering illness. So one out of 4 will probably die from a main non-communicable disease, like the cancers or chronic respiratory and kidney disease. 2/3 of all the deaths are due to non-communicable disease. So it 8 people die of cancer every day. So 5 of them in severe excruciating pain. So as to the cause of death in the Philippines, people regardless of the age who have a life-limiting illness needs palliative care. So again, it's not dependent on the specific medical diagnosis, but on the person's needs. So palliative care is required for a wide range of diseases. The majority of adults in need of palliative care have a chronic disease, such as the disease of the heart, disease of the vascular system, pneumonia, malignant neoplasms, cancers, tuberculosis, and so on. So, and with the passage of the National Integrated Cancer Control Act in 2019 and the Universal Healthcare Law in 2019, so it is expected to contribute towards the achievement of the national health objectives by catering to the health needs of the chronically ill and with life-limiting or life-threatening illnesses, especially those marginalized. And for this afternoon learning outcomes, of course, first is to identify the palliative care approach. Then second is to know the role and responsibilities of the palliative care nurse in home care setting. Third is to recognize the national framework of palliative and hospice care. Fourth is to know the national situation and policy related to palliative and hospice care in the Philippines. And of course, to identify qualifications of palliative care nurses and to identify LGU or companies which provide palliative care. And the last is to recognize the current challenges in improving palliative and hospice care. But what is palliative care? Okay, so according to the definitions of the World Palliative Care Alliance Declaration 2009, palliative care is the fundamental human right. So, meaning it is an essential component of comprehensive and integrated care for a person with serious, chronic, complex, and life-limiting or life-threatening health problems. So another definition, this is the active, holistic care of individuals of all ages and their families who are experiencing life-limiting illness. So meaning it is a planned care holistically through the illness that limits the quality of life. Okay, and another definition, according to WHO in August 2020, it is an approach that improves the quality of life of patients and their families who are facing problems associated with life-threatening illness. So palliative care came from the word palliate, so meaning to make things better. So this type of care is focused on preventing and relieving suffering through the early identification, correct assessment, and treatment of pain and other problems, whether physical, psychosocial, or spiritual. So how about hospice care? So hospice care, it is a component of palliative care that deals with the end-of-life care. So by skilled health care providers and volunteers. So usually to patients with about 6 months or less to live. So hospice care is not a place, okay? So it is a philosophy based on the individual's right to die pain-free and with dignity. So again, the goal of care is to help people who are dying to have peace, comfort, and dignity by providing holistic support or providing medical, psychological, and spiritual support. So hospice programs also provide support services, no, for the patient's family, usually in the end of life, anticipatory grief, or even up to 1 to 2 years of bereavement. Okay, so on these slides is the goal of palliative care is the achievement, no, of the best quality of life for patients and their families. So the primary aim of treatment, no, is not to prolong life, okay, but to make life which remains as comfortable and meaningful as possible. Okay, so as you can see, the quality of life model, no, shows how pain impacts, no, the quality of life by affecting the physical well-being, the psychological well-being, the social well-being, and the spiritual well-being. Again, the goal of palliative care is the highest possible quality of life for both patient and family, no? And because of the diverse needs of the dying patient, a team, no, a healthcare provider team is needed to provide the care and total well-being of the patients and their families. So who are these people, no? Sino tong mga healthcare providers na to? Of course, the doctor, the nurses, no? Or even the social worker, or the pharmacist, or the physical or occupational therapist, pastoral workers, and so on, no? So which provide the care for the patient and his family. So we call it a palliative care team. And yes, we work as a team, no? Okay, so how can we improve the quality of life? Okay, as you can see on this picture on the right side, no? Yes, it's true that patient has a fear of abandonment. Okay, so that's why touch is very important to provide comfort. Another picture, we have the palliative doctor specialist together with the nurse case manager and the palliative care nurse. They were all smiling, so meaning the patient is comfortable, no? And also on the last picture, ito yung pasyente, no? He was visited by his ministry, no, sa church, and of course, he play a music, no, and after a month, the patient was died, no. So yun. So then, but then how can we improve? No? Of course, we can improve the quality of life by preventing and relieving suffering through the early identification, correct assessment, and treatment of pain and other problems, whether it's physical, psychosocial, or spiritual. Okay? So yun. Okay. So losing sight of the goals of management may lead to inappropriate treatment, and also may provoke agonizing and difficult discussion, and of course a decision making. Okay, and as you can see, no, edematus, no, ang hand ng patient, no, and another picture, restless yung patient. So meaning the focus or the goal of care hindi siya na-achieve, okay? Which again will lead to appropriate treatment. Okay, so moving on to the palliative care models, no? On this slides, no, mapapansin mo, it's a coordinated multi-enter and transdisciplinary care system where the palliative care needs of patient and their family. So inclusive of all the people living with serious illness. So regardless of setting diagnosis, yung age or prognosis, are identified and meet at all levels that is beneficial, at any stage, at any stage of a serious illness. So here, palliative care is available before there is a need for hospice or end-of-life care. So meaning it is applicable in the early, applicable early in the course of illness. Okay, so before pa man mag-start, So in conjunctions with other therapies that are intended to prolong life with curative intent, okay, with curative intent, okay, such as chemotherapy or radiation therapy, and includes those investigations needed, to better understand and manage distressing clinical complications of the disease, okay. So many aspects of palliative care are also applicable, or needed, to better understand and manage distressing clinical complication. So as you can see, at the start of the diagnosis, the yellow triangle, see the bigger angle, on the left. So this represent, the peak role of a specialist, such as the oncologist, the surgeon, the radiation oncologist, the medical nutritionist, so in the care and the management of the patient. So at the start of the palliative care, the role of the team is minimal. So it's more on counseling and support, So it is an extra layer of care to help patient and their family cope better, to cope better. But of course, if the disease progressed, which is this one, the blue triangle, the role of the palliative care team becomes bigger, and the role of the specialist becomes lesser. So yun. Then follow by the end-of-life care and bereavement. So meaning it is a team approach to care. So, and palliative care does not replace the specialist that initially were taking care of the patient. So the specialist plus the palliative care team now becomes the multidisciplinary team, So until the end. So wala pong iwanan or toss over or transfer of service, as the patient and family might feel abandoned, by previous attending physician. So it depends on the patient needs, okay. When patient dies, okay, a bereavement support to the family can be provided by the hospice care, okay. So okay, so on these slides, ito naman yung transitions, in palliative care to hospice care. So there are two very different programs, yet they share the same goals and beliefs. So the difference is any attempt to cure the person's illness are stopped, because hospice care is an approach to care which can be offered, in the home or the facility, okay. Supportive care helps the patient and the family to cope with their conditions and treatment of it, So from the pre-diagnosis, okay, through the process of diagnosis and treatment to cure, no, continuing illness or death, and into bereavement. It also helps, no, it also helps the patient to maximize the benefits of treatment and to live as well as possible with the effects of the disease. So meaning it is given an equal opportunity, no, alongside diagnosis and treatment. Okay. Okay. So moving on to the principles of palliative care. Okay. So here, as to the principles of palliative care, the approach of palliative care use the principles, no, to affirms life and regard dying as a normal process. Okay, so here we respect life and also dying as part of life or a normal stages of life. So next, neither hasten or postpone the death. So appropriate treatment or treatment which is known to be futile given because you have to do something is unethical, where only symptomatic and supportive palliative measures are employed. So all efforts are directed, no, at the relief of suffering and the quality of life, and not necessarily at the prolongation of life. Next is to provide relief from pain and other distressing symptoms, no, such as nausea or vomiting, dyspnea, constipation, betrayal, no, and so on, no. Another, it integrates, no, the psychological and spiritual aspects of care, and also provides counseling and psychosocial support, no. And for the spiritual naman, it is strengthened, no, to patients and their families. Okay, and another principle is to offer a support system to leave patients live as actively as possible until death. So here naman, we offer a support system, no, to help the family cope, no, with the patient's illness and the loss of the loved ones. So in the process, actually we identify those family members, no, at risk for a complicated grief, no, prior to death, no. So this is where grief and bereavement services is very helpful. So minsan, no, after the passing, no, we call the family, no, kinukumusta natin, no, kung kumusta na sila, no, after na nawala yung or after the loss of their loved ones. Okay, so yun. So moving on to the levels of palliative and hospice care. Sorry. Okay, as to the level, no, again, of the palliative and hospice care approach, here in the palliative care approach, it is a principle that be practiced, no, by all healthcare professionals, volunteers, and family members. So it aims to promote both physical and social well-being. So in general, palliative care, at this level naman po, proportions of patients and families shall benefit, no, from the expertise of the health care professionals who, although not engaged full-time in palliative care. So, and at least dito po, there are some trainings, and ang HCPs has experience in palliative care. And for the specialist palliative care, are those services, no, with palliative care as their core specialty, and which are provided by the interdisciplinary team under the direction of the consultant physician in palliative medicine, or the palliative doctor specialist. Okay, and of course, here usually yung mga specialist palliative care, they're very they know how to assess, no, and treat complex symptoms, no. They also provide information and advice to the staff about the complex issues like yung mga ethical challenges, mga family issues, psychological or existential distress. Yun. So how does palliative care works? Okay, so it's a teamwork, no? It's a teamwork. So palliative care team works in conjunction with a primary physician and can offer assistance with the treatment of pain and other symptoms. So assistance with communication of bad news regarding diagnosis and prognosis, support for patients and families in medical decision making, and in navigating, no, the complex medical system, and emotional and spiritual support. So during home visit, the palliative doctor caring for a patient, no, together with the nurse, they would initially do the evaluation and symptoms assessment. And then communicate ito, no, communicate it to the team, and to know, no, the plan, no, for the management. Again, yung aim here is to palliate, no, the symptoms, managing the patient accordingly, and considering the inputs of all the members of the team, thus making it the palliative care team approach. Okay, so here we have the multidisciplinary, no, which provide, no, separate evaluation and give an specific goals based on own discipline, communicates it to the team. So like example is the oncologist, no, or the kanina, no, in our discussion, no, from the oncologist to the palliative doctor specialist, no. So next is the interdisciplinary. So it is a team which requires an interaction among the team members for the assessment and development of the intervention plan. So meaning the team determines, no, yung best method. Okay, so pag sinabing interdisciplinary team, so usually in my experience, kami once a week, no, pinag-uusapan yung status ng pasyente. Okay, so yun. So pag sinabi naman nating transdisciplinary, no, so it is the most prevalent model which calls for one team member to provide the intervention and to accomplish other members, no, which the other member must teach the service provider aspects of their discipline. Dito sa transdisciplinary, the nurses, no, requires the team members showing respect for each other, no, and you are willing also to share professional expertise, no, in order to promote alignment of the strategies, coordinated approach, and collaboration, no. Meaning the members of the transdisciplinary team cross professional discipline boundaries, okay, to achieve service integration by consulting with one another. So they do not abandon their discipline, but blend yung specific skills with other team members to focus on and achieve the integrated outcomes. So one person works most often with the family, and other members provide support through consultations and co-visit, which is nangyayari yan, minsan kailangan ng nutritionist, kailangan ng pulmonologist, So si nutritionist or si pulmo, which is through through virtual, and of course they coordinate with the palliative doctor specialist kung ano yung pinaka the best na management na gagawin sa pasyente. Okay? So yon. So where is palliative care provided, So yes, yung service level allocations for palliative and hospice care services across the different levels of care, So this shows that palliative and hospice services should be integrated across all levels of care, from the home to the communities and to the health facilities and hospital. So at home, so the patient should be able to receive hospice and home palliative care, Then end of life and bereavement care, nutritional services, occupational health support services. And at the community level naman, so in addition, diagnostic, such as mga basic, laboratory services, ER transport services, outpatient care, pharmacy services, support services, telemedicine, stand-alone palliative care, and long-term facilities, Then finally, for the level of specialized care, which of course could be found in the hospital, so it should include yung mga acute emergency care, inpatient care, critical care services, radiologic services, or respite care. So usually sa hospital, ito yung mga level 1 to 3, 1 to 3, and Apex Hospital, or outpatient or community, Okay, so what is home-based palliative care? Okay, so it is a health care or a supportive care provided by a team of professionals, healthcare provider in the home of patients. So it's also known as domiciliary care, social care, or inpatient home care. Okay, so how about the functions of the nurse? So ano nga ba yung functions of the nurse in the palliative care team approach? Okay, the nurse is highly skilled in pain management, okay, since it is the primary concern of the patient and their families. The nurse should also responsible, for educating patient and their families, not only on the pain management and on the other aspects of care as well. Okay. Okay. So moving on to the role. Ano ba yung specific role ng nurse, in palliative care? Okay. So usually the nurse is the one that initiate communication which respect to or honor the values and the health care wishes of the person and the supporting families. Okay, So another, yes, advocating, no, for and supporting person in their experience of living and dying. Okay. Another is to provide, no, provide holistic care or provide a comprehensive, coordinated, compassionate, no, to the persons and their family. Yeah. Also, the nurse will also, yes, as I have mentioned a while ago, no, attend to the pain and the symptoms relief, no, and of course, psychosocial, grief and bereavement, and support to maximize the person's quality of life and death. Okay, so another, the nurse should also provide compassionate and therapeutic presence, no, to persons and families, no, and including support for grief and bereavement throughout, no, the dying process, and advocate for the resources that support the person and family in choosing their prepared environment, okay, for the peaceful and dignified death. Okay. As to the primary and the community palliative care in the Philippines, no, so there was a devolution on 1991, Republic Act 7160, or the Local Government Code 1991, no. So the act by which the Philippine government devolved, no, basic services like health services to local government, no, levels, which focus on preventive and curative services, and fails to address the palliative and end-of-life care, especially in the community. That failures leads to the gap, no? So the gaps, like ano ba yung mga naging gap, no? So a general palliative and healthcare framework, no? And then the policies and guidelines, no? Human resources, training of medical professional and support staff for palliative care, public awareness, funding for palliative care, financial burden of the patient, no, monitoring and guidelines, no, availability of medication or pain relief, and then partnership between the healthcare professional and the patients, then community engagement or volunteers. Okay. And these figures, no, shows the framework, no, by which palliative and hospice shall be integrated into our health system, where community and hospital shall both be part of the healthcare provider network. Okay, so this network encompasses all levels of care, so that any palliative or hospice patient needing the service can enter the system ideally with a seamless experience of care management and referral through the proper channels. So maybe it from the home, from the compassionate communities, from the private or public sector. So the hospital, and encompassing even the workplace or other freestanding hospice facility. This can be done through building commitments and cooperation coming from the different stakeholders, no, especially through the leadership of the DOH and different local units, no, as well as partnering with the PhilHealth, no, to ensure a better financial health coverage, no, to include palliative and hospice services. Also making sure that there is an interoperable system for the palliative care registry, which is a vital, no, for making this network as a successful integration to achieve universal health care. Okay, so, okay, as to the achievements, no, so as to the achievements, the Philippine healthcare system has come a long way, no, through the years. So, and in light of the implementation of the National Integrated Cancer Control Act, the Universal Healthcare Act of 2019, and the Department of Health Administrative Order number or Administrative Order 2015-0052, National Policy on Palliative and Hospice Care in the Philippines. Therefore, we are on the right track, no, towards ensuring a holistic health care. So including quality palliative care, which is accessible, no, for all Filipinos in the various healthcare settings. So yun yung achievement sa ngayon, no? And aside from that is the implementation, no, of the project to develop the manual of operations, which include yung primary care standards, yung essential medicines, equipments, and supplies, so essential staffing in primary care, and also we do have now standards for the basic training manual, no? So we have this participants manual and facilitator manual, no? And mostly yung mga participants are the community doctor, nurses, midwife, no, physical therapists, social workers, religious workers, and etc. The manual is developed, no, to assist the national and local government unit health program implementers towards achieving, no, the goal of integrating palliative and hospice care in the Philippines. So in the Philippines, no, so it is in line as I have mentioned a while ago, no, with the National Integrated Cancer Control Act and the Universal Healthcare Act. So since it shall describe palliative healthcare programs across all levels of care settings, also it can be used, no, to guide local stakeholders in driving into operation the national policy on palliative and hospice care in the Philippines. It is yung basic training manual naman is written, no, for all the healthcare professionals, no, and careers which involve in the provisions of palliative and hospice care across all levels of care setting, from the home communities, including the workplace, and to the hospital, or even yung mga special populations, so kasama, so that they can strengthen, no, yung local system and resources for an integrated and seamless transition and navigation of the palliative and hospice patients and their families. Okay? So yun. So what are the public health nurse qualification, no? Ano yung qualification mo? So of course, training, no? So a minimum of intermediate training in palliative and hospice care, no? So in order to expand care not just from the hospital but to the community and the primary care facilities, and of course to promote a multidisciplinary approach. So through training from primary care providers achieve the universal health care is possible, along with legitimacy and support from the government, as well as concerted efforts from various stakeholders. Yun. Another communication skills, including the children's and families, no? Understanding a childhood development and rights, initiate and provide the nurse-led home care and at the primary healthcare center. So the training should be provided first to the medical doctors, no, and the nurses at the RHU or the CHU. Ayun. So they should receive at least 40 hours, no, of combined theoretical and practical training in palliative care. Intermediate training at the minimum. And then once na-train na, no, of course, they can participate, no, for the training of other nurses or the barangay. They can also train the barangay health workers, no, or volunteers, or even the midwives, no, at least one per barangay. Okay, so yun. Okay, so for this training, actually, it will further enhance, no, the knowledge base of the participants while expanding the critical mass of participants will be trained with the basic concepts of palliative and hospice care. As this is the pilot training, we're done with this, no? But then it is likely some aspects of the training operations and goals was not achieved, no? Especially it was given during the pandemic situation, which is supposed to be a blended. So ang nangyari virtual lang, no? So, however, yung pilot training na yun provide, no, as a valuable details and realization as well as focus point for improvement. So, lastly, as this is a part of the DOH initiative and pursuit to increase the number of patients, no, who will receive palliative care, as well as trainers who will share knowledge. So the training must be aligned with desired competencies in accordance to the DOH plans for human resources for health. Okay? Ayun. So, dito naman, on these slides, the establishment of the integrated palliative and hospice care in the Philippines is still work in progress to death, no? But the provision, no, of palliative and hospice services available na siya, no, in many parts of the country. And current services in the Philippines, we have 34 organizations which provide 108 hospice and palliative care services. Alongside these providers, a wide range of group gives compassionate care to the dying. So starting in the 90s, no, several disease specific programs has been developed to cater to the community or a special population group, no, to provide home care that incorporates the model of palliative and hospice care. So the following is the list of such program, no. First, we have the hospice home care program by the Philippine Cancer Society. They do home visits, no, for cancer patients within Metro Manila. Next is the Kite Foundations in East Avenue Medical Center. So it's a child life program and care for children. And then Madre de Amor Hospice in Laguna. They do also home visit and care of cancer patient, psychosocial and volunteer program. And Ayala Alabang Hospice in Muntinlupa, it's a church-based home care. Next is the Starship program in San Lazaro Medical Center. A program, this is a program for a rabies patient, no? We have the Palcare Volunteer Group, no? So this is the first, no, palliative care volunteer group affiliated with an academic medical center to gain recognition from the DOH and Philippine Cancer Society. And we have the Palcare Hospice Foundation, no? It's the first community-based, no, home care serving in the province of Bulacan, linking both the LGU and the provincial hospital or the Bulacan Medical Center. We have the Root Foundation for Palliative and Hospice Care. So ito naman, a community-based service for homebound elderly and patient, no, with life-limiting or life-threatening illness, and palliative hospice care education for nurses. Okay, volunteers and other community-based health professionals. Okay, next is the Active Care Home Health Solutions Incorporated. So it is a private company that provides coordinated palliative and hospice care services for continuity of care, transitioning from the hospital to home care by a palliative care team. Ayun, so So who provides, no? Who provides palliative care? Again, I would like to emphasize, no? Active care is a total home healthcare provider that offers, no, a complete range of services. So these are, no, for active care, these are the services, no, na ino-offer, no, sa bahay sa mga pasyente namin. So meron tayong nurse case management, no, wherein ang doctor, no, and the nurse case manager will visit, no, once a week or depends, no, kung kailangan. Then another, we have medical supplies also, laboratory, pain management, medication management. So lahat na, no? So we can provide it at home, no? So yon. So again, your health is a priority of active care. So, and believe that compassionate care is best given at home, the primary touch point where active care's promise, no, comes to life. Yon. Okay, so again, so prior to deployment, we train our palliative care nurses and palliative health aides. Okay, so as for the current situation now, no, of the palliative and hospice care nurses specialists, so we have this career progression and specialization, no, which provide an advanced specialty training for registered nurses. Dito, actually at this point of time, no, there's still on the process, no, for advanced professional nurses on their field of specialization in the country. The Palliative and End-of-Life Care Associations of the Philippines, or PELCAP, had been created, no, by the palliative care nurses and was endorsed, no, by the Philippine Regulatory Board of Nursing, with the objective to establish a national standard and certified nurses as palliative care nurse specialists, no, as per recommended by the certified organization for the career progression and specialization for nursing. Okay, so yun. So be a member, no, be a member of PELCAP. Okay, so yun. Okay, so yes, this is our SIC registration, and this is the certificate of no objection coming from the PRC. Okay, so part of it is our advocacy, no, advocacy of PELCAP. Okay, so we do, yes, training, most likely a seminar, no, to the nursing students, no, depending, no, in a different or within NCR or provinces, no, about palliative and hospice care. Ayun. Another, yes, we offer this also, no, to the faculty, the College of Nursing. Please let me know, no, if one of your colleagues need access, no, to free faculty, no, curriculum, which is an online training, no, from an ELNIC Relias Academy. Okay, so dito kasi naka-attach yung mga faculty material to supplement the curriculum, as well as to help guides for faculty, no, to pass along to their students. Okay, so towards the pandemic, no, across the country, palliative care team are asking themselves, no, what are the rules, no, in supporting patients with long COVID. Okay, so as a palliative care leader, it shares how the team is navigating, no, the ongoing crisis and discusses the long COVID or the team preservation. On my experience, we have a COVID team and we have a palliative team. So once our patient nagpa-positive sa COVID, so ini-endorse namin sa COVID team. Okay? So again, we are nearly 2 years into the COVID-19 pandemic. So although at times it seems like it is stretched on even longer, no, than that. So it's taking a toll on everyone's, our patients, their families, our colleagues, and ourselves. So as a palliative care specialist, no, so we were trained to address the challenges, no, that people have and we are experienced and dealing with uncertainty. But we aren't accustomed, no, to an ongoing crisis like COVID-19. So it's been challenging to cope with this trend that it's placed on the healthcare system and on us too. So palliative care status has evolved during the pandemic, no? So one small masasabi nating silver lining on the pandemic has been our field's chance to show others, no, just how important this type of care really is, no? So in fact, as the pandemic unfolded, so many clinicians have developed a deeper, fuller understanding of the role of palliative care. Why? Because some of the patient, no, they don't want to admit in the hospital. Gusto nila sa bahay lang. So the clinician now know how to help their patients. So, and 2 years into the pandemic, they have a much greater appreciation for what the palliative care team brings to the table, okay? As they can educate others about the role of palliative care too. Okay, so this presents an interesting opportunity, no, to all of us who champion palliative care. We have demonstrated the importance of the role of palliative care in supporting people experiencing an array of outcomes from COVID. So we have shown the value of good communication with our fellow team members and with our patients and their families during the pandemic. So here's our chance to capitalize, no? So we can continue to build on these achievements. So educating others about our role and finding new ways to meet the growing need. We can tell healthcare leaders about our successful efforts. So we can demonstrate the value of our work to everyone we encounter. So it starts with us. Okay, so as for the current challenge in improving palliative and hospice care, so on the personal level, so yes, we are talking about the knowledge, the attitude, the beliefs, or the skills, or the culture, no? So the low awareness or even lack of awareness of healthcare professionals about the need for palliative and hospice care, not only in cancer, but especially in chronic, no? Non-cancer disease is a challenge, no? Presently faced by this program. On the healthcare system or level, workforce, access to drug, resources, and training. So that's another challenge, no? So sometimes there is an impaired with the health and medication literacy among patients may result in some resistance to or be unaware of the need for. So early treatment and palliation. So this also plays a big factor, no, in a low demand and utilizations of palliative and hospice care services in the country. So another, we have the organizational level. Yes, it's contribute to the current challenge in delivering a quality health care, including palliative and hospice care, especially in the geographically isolated and disadvantaged areas. Okay, and of course, in the policy level, yes, there is a fragmented efforts, among the stakeholders, in the implementations of palliative and hospice care services. Also, is a barrier in achieving a holistic system of service delivery across all levels of care setting. Okay, so yeah, and for that, okay, where would you like to be at the end of your life? Okay, so again, don't be wired for life, provide a plan of care, for the dying process can be helpful, for clients and families. So many times, the directives I am reading from is very different from the one that my patient and family have. And please be ready, when the plan change. Again, don't be wired for life. Caring for a patient with life-threatening and advanced illness is never an easy business. However, we do have tools to help ease this part of life. It is our job as healthcare professionals to use them fully and to use them promptly. So now we have no excuse. Thank you.
Thank you very much, Ms. Rose, for the very broadly information regarding the palliative care in the Philippines and for inspiring our fellow nurses and aspiring leaders. May you continue your great influence on the upcoming generations. This pandemic affects all individuals who need medical care or attention. Those who regularly go to the hospital for the checkup or require medical assistance are now afraid to go because of the threat of COVID-19 virus. Using modern technology and innovation, we are now easily able to reach medical access and services. We will now move on the next portion of our program. May we call Ms. Cheska Rojas, our moderator for the question and answer portion.
Thank you, Mr. Christian. Before we start, we would like to thank everyone who participated in this meeting today. We will now proceed with the most exciting part of our program, the question and answer portion. Also, for those who have questions, now you can send your question in the Q&A section, and we will try to address them to our guest speakers. Please include to whom the questions are addressed. These are some questions taken from our registration link and from our social media platforms. Okay, so our first question is from Mr. Cresar Zairus Morato of CTU Tuburan Campus for Ms. Marinette de Vera. I will just read it out. How safe is it against radiation when using technology as an alternative way of communication to healthcare?
Thank you for that question. So it is completely safe. Radiation is everywhere these days, remember. Nowadays, technology is everywhere and a way of lives. A good example is us, OFW, who is using video calls to communicate with our family at a distant site. So as the telemedicine it is where physician can communicate to their patient even miles away through their video conference, and it is not as equivalent to the radiation that is present when we had procedures such as X-rays, CT scans, or any other procedures that having radiation. Thank you.
Thank you, Ms. Marinette, for that informative answer. Our next question is for Ms. Milagros from Ms. Connie Badua from the University of Perpetual Health, Isabela. Ms. Milagros, what is the difference between the care you provide in home care versus hospital care?
Okay, so as we discussed a while ago, no, patient is comfortable at home because of the environment which is familiar to them. Then in the hospital, that there is visiting hours. So aside from that, at home, no, the patient and the family has a shared decisions with the team, no, to plan the goal of care, unlike in the hospital, which focus on the curative treatment, no. Another, I think it's in the hospital then, no? We have a 24 hours care rendered, no, by the professional nurses, whereas at home, it's the option of the family if they will get professional nurses or caregiver, or enough for them, no, na i-home visit lang ng doktor once a week, and then the family will take care of the patient. So yun po. So again, with the right kind of support from the reputable home care services, so your loved one will continue to enjoy, no, an independent and a dignity from the comfort of their home, whereas in the hospital care will only be necessary once they are completely, no, dependent on the nurses and need around the clock access, no, especially on the skilled nursing service. Thank you for the question.
Thank you, Ms. Rose Lewis, for that wonderful answer. Here's another question for Ms. Marinette. This is from our social media platform from Ms. Arlene Mandal, nurse from Camp Nakar Station Hospital. Ms. Marinette, how can the use of telehealth technology in healthcare affect nursing practice?
So the use of telehealth technology in healthcare affect nursing practice in a sense that telehealth eases the impact of nursing shortage across the world. With this day and age, we are all aware that nursing profession is declining in numbers due to many factors such as retirement of nurses. Nurses now, if using this telehealth medicine, nurses can solely focus on patient care and satisfaction without all the red tape of traditional on-site appointments. It makes healthcare systems efficient and can be accessible to all our clients across the world. Thank you.
Thank you, Ms. Marinette. The next question is for Ms. Milagros from Ms. Rochelle Romero, a nurse from UAE. Ms. Milagros, what is the most challenging task of a home care nurse?
I think the most challenging task of the palliative care nurse and the palliative health aide is to provide quality of life, okay? Which includes the most challenge, no? Especially kasama yung 4 dimensions of care, which is the physical, the psychological, spiritual, and psychological suffering of the patient. So that's the most challenging. Thank you.
Thank you, Ms. Milagros, for that wonderful answer. So for our last question is addressed to Ms. Marinette. This is from Mr. Rain Bautista, CQI nurse of Al-Hada Armed Forces Hospital in Taif, KSA. Ms. Marinette, what are the major challenges you encounter during establishing telemedicine clinics in your hospital, and how patients in Saudi Arabia respond to this innovative change?
Thank you for another questions. So the major challenges that we encounter during the establishment of this telemedicine in our hospital is that, like any other new services that being offered in the market, of course, we have to gather a team and made a lot of research to ensure that telemedicine will have a better impact on our clients. We also had the challenges on how we can reach out easily to our patients using this innovative technology. We also thought on how we can come up on a virtual application that would be efficient, user-friendly, and will fit all the needs of our clients. And another challenge that we face is that we thought about Saudi Arabia on how we will consider their laws, customs, and even their traditions that we have to respect in spite of innovative journey to the telehealth. While how the Saudi Arabia respond to innovative change of telemedicine, So of course, with the help of our computer ITs that made a lot of patient notification, to educate our patient and introduce virtual care to our clients, while on the other hand, our physicians, during the patient's visits, they continuously and patiently educating our patients regarding virtual care and how it will have the convenience on seeing them during the pandemic. Eventually, patients here in KSAs, particularly in Taif, Saudi Arabia, they started to accept telehealth or telemedicine with wholeheartedly to these new steps of change for telemedicine. That would be all. Thank you.
Thank you, Ms. Marinette, for that thorough answer. That is all for our Q&A portion, and thank you for our speakers, Ms. Marinette and Ms. Milagros, for addressing our questions and concerns. For the participants, thank you for raising your questions. We hope that all of them were addressed and clarified by our guest speakers. We will now move on to the next portion of our program. May we call Ms. Jenny Ann Bautista, our moderator for the awarding of certificates.
Thank you, Ms. Cheska. The Filipino Women's University Graduate School of Nursing, Master of Arts in Nursing, hereby awards the Certificate of Appreciation to Ms. Marinette de Vera for her enthusiastic participation as the guest speaker of this event entitled Catching Up with Nursing Issues and Trends, Healthcare Innovation in Times of Pandemic, given this 12th day of March 2022 at the Filipino Women's University, Manila, Philippines. Signed by Christian Bert A. Martinez as the webinar chairperson and Dr. Minerva de Ala, Dean School of Nursing. Please accept as well from the PWU and the organizers this small token as a gesture of our heartfelt gratitude for being one of our guest speakers. Thank you, Ma'am Marinette. The Philippine Women's University Graduate School of Nursing, Master of Arts in Nursing, hereby awards the Certificate of Appreciation to Ms. Milagros Nuez for her enthusiastic participation as the guest speaker of this event entitled Catching Up with Nursing Issues and Trends, Healthcare Innovation in Times of Pandemic, given this 12th day of March 2022 at the Filipino Women's University, Manila, Philippines, signed by Christian Bert A. Martinez as the webinar chairperson and Dr. Minerva de Ala, Dean School of Nursing. Please accept as well from the PWU and the organizers this small token as a gesture of our heartfelt gratitude for being one of our guest speakers. Thank you, Ma'am Nuez. I am honored to award this Certificate of Recognition to the Group 4 of Section DEP 09A for their valuable and outstanding contributions to this nursing webinar. For without them, none of this would be possible. Our program chairperson and master of ceremony, Mr. Christian Bert A. Martinez, for certification, arts and design, and program organizer, Ms. Maria Francesca Rojas,
and for tokens and program organizer, to Ms. Jenny Ann Bautista.
Before we end our program, may I invite again Mr. Christian A. Martinez, graduate student, taking up man to deliver our closing remarks.
Thank you, Ma'am Jen. To begin, I'd like to express my gratitude to all of you, the speakers, for your excellent and well thought out presentations, the organizer for animating this webinar, and keeping things under control and on time. Dr. Dean Minerva de Ala for her guidance and support, and our dear Professor, Dr. Mark D. Santos for his unwavering support. Finally, and most importantly, I want to express my gratitude to all of you, the members and participants. This webinar would not have been feasible or successful without your participation, thoughts, and discussion. Listening to our brilliant speaker has been a fascinating journey. We are certainly refreshed by the lesson we have learned in the past as we listen intently to them. There is always no doubt that we learned something new today. Today, we are armed with new information that will help us become more globally competitive in dealing with our nursing clients. As we face the world, may the transformation that is expected of us be visible in our interaction of us, colleagues, subordinates, if any, and most importantly, our patients. Thank you very much, and may God bless you all.
Thank you, Mr. Martinez, for that inspiring message. Finally, we would like to thank everyone for attending and actively participating during our program. We hope that you were able to learn so much about technology in healthcare and palliative care in the Philippines, and apply this to your learning when you go back to your institutions. For our participants, the evaluation link is posted. Please accomplish the form and submit accordingly. The certificates of attendance will be sent to you within 7 to 14 days. You may also scan the QR code to access the evaluation link. In case you did not receive your certificate of attendance, you may contact us. We would like to encourage everyone to stay until the end of the Philippine Women's University hymn, as the evaluation link will be posted again after the hymn. On behalf of PWU Graduate Studies, School of Nursing, once again, this is Cheska Rojas,
Jenny Ann Bautista,
and Christian Bert Martinez.
Thank you, and we are praying and hoping for everyone's safety.